that's the best and that's the great. So principles of pharmacoeconomics and health economics. Actually, what are the aims of pharmacoeconomics? Actually, first, the definition. What is a pharmacoeconomics and what is health economics? And what is the need? The first question is in our mind. It is good for all of the questions about pharmaco and health economics. What was the societal need? What was the need for a health economic way of thinking? What do you maybe as emerge in your mind? Always you should think about one.
Benefit-risk ratio, it was something like that.
One slide. In all pharmacoeconomic questions you can sell it to Professor Watts. That this question is...
you mean gap?
Yeah, the bridging the gap. So what is here? We have an exponential, this is decades. This is from 1970 until nowadays, and if we continue, we have fantastic new scientific, medical things that we should apply. But here is our economy. This is science, and here is nothing worse. This is science.
Let me go to downset and being a new one, yeah?
Pardon?
Do you need
I
new marker?
Downset and being new marker.
That's another one.
Vagy este başa.
There's one. Yeah. So this is science.
Azt nézd.
No, this is economy.
Van gefámulom, gap nincs.
And science. So our economy is, constant economic crisis. Always in your profession, you will face the fact that for everything that will be the answer, no money, no money. We have a new thing, new fantastic thing, no money, no money. So the patient will get the old traditional answer. Or, if we have this kind of way of thinking that this gap is constantly growing, in health economics, which is all about the health economic, all about the, for example, the prevention program, comparison of two surgery program. And pharmacoeconomics is the part of health economics, the small part, which is only concentrate on drug therapies. So that's only the difference. So here we have as a health economics, and this is pharmacoeconomics. Yeah. So all the same, everything is the same. That we just try to evaluate medical procedures, surgeries, drug treatments, and so on and so on. With the outcomes, and not only the clinical outcomes, but the economic outcomes. And health economics is for every kind of health, and pharmacoeconomics within this great family, only the drug treatments, drug therapy effectivity we concentrate on. So we always have to face the fact that all these things that you may think, stupid things, the decision analysis, social, and so all of these were just figured out. How can we solve the problem that we have limited resources from money, limited resources from economy, but great amount of patients who want to be cured. And we just have to decide which treatment we must prioritize, the word prioritize, make this first, spend the money to this, because, for example, there is treatment A, just in general, treatment A, we can heal 2,000 people, and with treatment B, we can heal 3,000 people. And that's why we have to, with this kind of money and with this kind of money, so that we always have to, in balance, outweighing that what are the clinical outcomes and the economic outcomes, and the most aim is our aim that we must use our limited resources in a way that more and more people must be treated. And we just threw away those therapies which are, in pharmacoeconomic studies, proved to be not so good, not so cost effective. Because here, money saves lives. If we can gain some money, because the other treatment is better, then it will be for 2 or 3 patients better treatment, and maybe he or she won't be dead. Or he or she, this patient, will have a better quality of life, because for drug treatment A, there will be 2 years of life years gained, or and for the others also 2 years. But for the second, maybe it is cheaper and the quality of life of the patient is better. That, for example, for drug B, the side effect of this drug B is not so tragical. That's why it is cheaper. We always have to think about the price and the side effects and the main effects. And from these, together with pharmacoeconomics, all this decision tree and SOJA, we just put together that finally, which will be cheaper for the society and better for the patients. Yeah, so this is the need for these pharmacoeconomic evaluations and health economic evaluations. Actually, in general, you can use these two as equals. Only that if you are asked, for example, that what is the difference, you should have to know that pharmacoeconomics is concentrating everything what is health economics, but it concentrates on the effectivity of drug, cost effectivity of drug treatment. But these two terms, pharmacoeconomics and health economics, actually you can use totally equally. That they are equal actually.
Okay, aim is less price by more patient treatment.
Absolutely. But
And quality of the treatment, how to say? For example, we have A and B. There are
yeah.
A, we can treat it without more expensive and without any side effect, and B is more cheaper
Yeah.
and have a lot of side effects.
Yeah.
Now, what we compare between
That's pharmacoeconomics. Sometimes the more priceful, the more expensive is the best. That's what means, for example, cost effectivity analysis, that maybe we have a drug A which is more expensive than drug B. But if we consider the outcomes, that for example there is a side effect, and curing these side effects for every patient is $200, and we can add all together these side effects. For example, with the decision tree, you can make an example. And finally, maybe in that example was concretely the interesting that the cheaper, the more expensive, or the best, or the better. So, pharmacoeconomic way of thinking is absolutely crushing that way of thinking. This is the cheaper, we have to do it, because it sees the end. And maybe the end, the cheaper will be more expensive. Why? Because it will have severe side effects or other social burdens, or the quality of life will be, the patient is very bad, that's why the patient can be work, that's why his mother can give him the money, or the family have to deal with the patient. So pharmacoeconomic way of thinking is not about cheapness, absolutely. It's about, in the end, we should concentrate on the outcome, the clinical outcomes and economic outcomes, and we have to, as a way, balance them out with mathematical formulas, and these are, for example, decision tree, what you have made, or the SOJA analysis, and so on. So these are the practical aspects, but the theoretical aspects of this is for pharmacoeconomics. So let's now just what I mentioned quickly. Can you, would you mind if you just go here and I just put some interesting, so the most important things about this pharmacoeconomics. You can sit here.
No, I sit here.
Do you see? Okay. That's what's pharmacoeconomics. Okay. Okay. This is the figure. Actually, this figure in every kind of pharmacoeconomic you can sell it to Professor Watts. So these here are the time and the years the economy is or even stagnating, and we have this gap. And why do we need all of these economic evaluations here? The cost-effective, cost-benefit analysis, cost-utility analysis, or the SOJA, everything what is pharmacoeconomics. The starting point is this. Do you freeze or?
Yes, I don't know why here it's so cold.
I think it's
okay.
It was very, very bad smell, and that's why. Okay, so this is our extent of resources. Our extent of resources scientifically are fantastic, wonderful new treatments, but we cannot give them to the patients because no one will finance it. That's why we have to decide. It's a very hard decision. That's why we have to decide with correct mathematical and biological formulas what patients and what population should be treated, because the the health gain must be maximized. So the health gain, the gain of health of the whole society must be optimized. It's a cruel and very cruel and brutal question. For example, we have, just to keep it simple, we have money for curing 10 lymphoma patients with a new fantastic treatment, and we have money. This money is actually all the same as curing 2,000 arthritis patients. What should we choose? In that, it's just a theoretical example. We should maximize the gain of health. That's why we have to choose. It is good for 2,000 people, and the price is the same. So we have to choose this. Of course, these lymphoma patients must be cured, but not with this fantastic new evidence-based method, but maybe with those methods who was already applied 10 years ago, because there is no other choice. So it is about saving life and life of people and life of patients and death of patients. That's why it's a very severe question. So they have to make social decision analysis, health cost effectiveness analysis. They always have to make a very transparent and logic systems how to decide to give our limited extent of resources to the whole society. So the health gain must be maximized. Also important, what are the main reasons for this, for the increase of because the healthcare costs are constantly increasing. All of this, actually, I'm sure that you know this, what are the main reasons. Some of them should be memorized also, that why our healthcare costs are constantly, it's a kind of a very sad axiom. It's a very sad fact that healthcare costs are constantly, in the recent decades, it's constantly growing. And how should we divide or allocate these healthcare services? Because there is no hope that everyone will get the best available therapy. We have to make severe compromise, and with these pharmacoeconomic methods, we make the compromises. So these sentences, I think, very good to memorize, because not so many. There are not so many sentences, but in an exam it can be. If you memorize these, it's a very good form to. We use our resources, our very limited resources, in a way that generates the greatest possible benefit for the patient, for the whole society. And here are some basic definitions. If we want to define pharmacoeconomics, we should define what is a cost. Because cost is not equal as money, as you remember. It is the value of our resources which are consumed. And always there is a cost, and always there is a consequence. And an economic evaluation may put these together in comparison, and the pharmacoeconomic evaluation is what we just discussed about. Outcomes, we just used it very much time, so very often. Always the outcomes can be very different. It describes the results and the value of healthcare intervention. Can be clinical outcomes. For example, it's a kind of this new drug significantly lowers the more cardiovascular mortality. It can be economic outcomes also. So we, as we mentioned, that can be humanistic outcomes where the patient's point of view is also, the patient is asked, I don't care about your blood pressure. I am caring about how do you feel your quality of life is. It's a score with a score system. Of course, it is scientifically professional. It's made by scientists, pharmacoeconomic medical doctors and pharmacists. But the patient is on the quality of life questionnaire. The patient gives scores, and finally there is a score that the patient's quality of life is good, not good, or bad. And in these humanistic outcomes, it is also important. Okay, cost. Direct cost, indirect cost. And here is a good table about what is, you should remember, the direct cost and the indirect cost. So direct cost is always, can you directly measure in money.
This is very difficult table.
It's a difficult table, but maybe the examples can help. So what is a direct medical cost, which you can pay, a hospital fee, the drug, it has a price. Result from the illness or intervention, it has a price, and there is direct non-medical cost. For example, we have to transport for the patient, or the family members of the patient can take care, and it's, for example, 10% of the salary of the sister or brother of the patient that he is just giving them the food and go to their home, to the patient's home in every day and just take care. There are direct costs, but non-medical, and there are indirect costs also, which you cannot measure directly in money, but with mathematical certain kind of formulas, experts can earn it, experts can count it, calculate it. For example, the earnings lost during illness. We can calculate it that I am from now until, for example, in whole November I was just ill, so all of my lectures were lost and all of my jobs were lost, and indirectly it is a cost also, because anyone else can do it, must do it. For example, after the end of his work time, for example, Anna's work time after 4 o'clock, she has to work instead of me. There are indirect medical costs. And indirect non-medical costs, for example, we cannot really measure cost as a quality of life. It's kind of, it's the most complicated. Only this one example is enough for you. And these altogether, these 4 gives the sum of the total cost of the therapy. And these are very important. What are the pharmacoeconomic analysis? Maybe this is also important, but for us pharmacists, these cost-benefit analysis and cost effectiveness analysis, cost-benefit analysis. There is a way, and there is input and output. And in the cost-benefit, here's the key: the inputs and outputs are measured with money. The costs and the benefit are always measured with money. It can be very useful, but cost effectiveness analysis is maybe it is the most often type of pharmacoeconomic, because here the input is in monetary terms. That means you measure the money, how much were spent on this therapy, but the consequences are in non-monetary health outcome. What can be these? For example, years of life gain, symptom-free days in asthma or migraine, or blood pressure reduction, or avoided disability days. So the quantity of these days, and there is one. You will read the examples, and the last is a cost-utility analysis. Here, what is the difference between cost-effectiveness analysis and cost-utility analysis? It also measures the input in money, but here is one key word what you have to remember: cost-utility analysis. It's not about these kind of avoided disability days or blood pressure. It's about quality of life. You should always remember cost-utility analysis measures. The utility is measured with quality-adjusted life years. That means that not only the quantity of the patient is delivered, but the quality. Drug A gives me, as a cancer patient, 3 years more life. And I am in bed. My quality of life is tragic. And drug B gives me also 3 more reasons as a cancer patient, but I can work for it, or I can chess. I can play chess. It is my favorite hobby. That's why I score my quality of life as a patient. It's a subjective thing. This drug B calls me a much more better quality of life. It is a more refined analysis, this kind of cost utility, because it takes into consideration the patient's point of view, his or her quality of life. Not just the quality, but the quantity of life is also measured. These 4 are actually also the cost illness. These 5 have to be remembered. Here, the cost of one illness to society is measured. For example, we are doing asthma research in Hungary in the last 10 years. We just make researches and observations that how much direct and indirect costs caused these kind of, for example, severe asthmatic, and I report as a patient in the 5,000 patients which were involved that I couldn't work from 365 days, I couldn't work 20 days. That's also an indirect cost. So this is the cost of illness. But for us pharmacists, these other 4 must be remembered and just defined. And here, what are here said are absolutely enough, and there are always examples for them. Okay, and cost minimization analysis. You can only apply cost minimization analysis if there are two, drug A and drug B, and the outcome are absolutely the same. So both drugs, for example, we can further develop causality, these cancer drugs. For example, drug A against cancer and drug B against cancer absolutely cause totally equally good quality of life. And then comes cost minimization analysis, which means which one of them is the cheaper.
Yes.
All of them causes the best quality of life. Which one is the cheaper? That is cost minimization, but there is an extremely important here that only when equivalency of outcomes can be scientifically defended, then only we can apply this cost minimization analysis. If they are not equally, then forget it.
We cannot compare them.
Yeah, then we cannot compare. We should compare with other kind of ratios. Okay, and one very important, maybe you remember about this. It's a key. Efficacy is about what? Clinical efficacy. Under very strictly controlled conditions, only there these kind of patients are involved. It's a sterile conditions. In a clinical trial is extremely well controlled. Everything is documented, and effectiveness is in real life. Nothing is documented. Maybe the patient don't care and doesn't take this fantastic drug because it has for example, an unknown side effect, and oh, my stomach is aching, I don't care. I have 2 times per day, but I only take it 1 time because it's hurt me. And this is effectiveness. These efficacious drugs are put in the real life, in the arena of real life, in the dangers of side effects, non-compliance, interactions, and so on and so on. And in this big arena, they are just fought by other factors, and then the efficacy will drop as effectiveness. In lucky situation, they will be same. That's a fantastic drug, and it will be a very evidence-based, successful story. So this is the difference. This is pharmacoeconomics. Then, okay.
This part is finished now.
Yeah, this is the first is finished. Then we have here hospital and clinical pharmacy, life stages, pediatrics, geriatrics.